afternoon, everyone, and welcome to the Community Science webinar, How to Assess the Effectiveness of ACA Outreach and Education Efforts. I'm Kian Lee, Principal Associate and Vice President at Community Science. I've been at Community Science for 18 years and have research and evaluation expertise working in partnership with federal agencies such as the Office of Minority Health and also with foundations such as the Kellogg Foundation, the Colorado Trust, and the Connecticut Health Foundation to address health disparities reduction, immigrant integration, racial equity strategies and programming, and development of cross-culturally competent organizations.
Good afternoon, everyone. My name is Oscar Espinoza. I'm a Senior Associate at Community Science, and I served as a Project Director for the evaluation of the ACA outreach efforts that we will discuss today. I also currently lead the project we are conducting that's evaluating outreach and education strategies for the Office of Minority Health. I have 16 years experience conducting research and evaluation work in topics such as access to care, health disparities, and healthcare quality for underserved populations.
Hello, everyone. My name is Jessica Bodiani. I'm an associate here at Community Science and have been coordinating our work on the ACA evaluation project over the past year. I will facilitate the question and answer session following Oscar and Kian's presentation today.
Thanks, Oscar and Jessica. So for those of you who are not familiar with Community Science, we're an award-winning research and development organization that works with governments, foundations, and nonprofit organizations on solutions to social problems through community and other systems changes. Since 1997, our objective has been simple: to develop the knowledge necessary to address social problems in a way that benefits all communities. We provide an integrated approach to building the capacity of organizations and institutions, combining the principled, rigorous use of scientific methods with practical tools to foster learning and improve capacity for social change. Today's webinar will share practical strategies to assess outreach and education efforts used to inform hard-to-reach, racially and ethnically diverse populations on the Affordable Care Act, which we will refer to as ACA throughout the session today. Our focus will be on lessons learned from an evaluation conducted by Community Science of several local efforts during the first enrollment period. We are still collecting data for the second enrollment period, and hopefully we'll be able to share more insights later. So for today's agenda, we will first provide an overview of the project and the context of this work. Then we will present the methods we use to document and assess the effectiveness of ACA outreach and education efforts conducted by the NPA RHECs, which I will explain in a little while what they are. Next, we will share the results of the outreach efforts in terms of reach, knowledge gain, and intent to take action to enroll. Then we'll summarize our key lessons learned for overcoming barriers to enrollment, designing effective outreach strategies in future enrollment periods, and evaluating the impact of ACA outreach. Then we will leave a good chunk of time to go over and address your questions during the Q&A session at the end. Before we begin, I just have a few instructions and information about logistics for you. Here, you will see a picture of what your dashboard should look like. Use the arrow highlighted here to open and hide your control panel. The audience is in listen-only mode, so you won't be able to unmute yourself using this icon, which is why you see it's grayed out here. To join audio, you can pick either the mic and speakers for voice over IP or telephone, as shown here. Finally, here is the questions panel, which you can use to A, troubleshoot tech problems, B, submit your questions and comments. And this part is important. Because of the large number of people attending this session, we will not be able to open the floor to participants for discussion during the presentation. Therefore, we have disabled the raise hand function on the dashboard. However, as we go through our presentation today, please feel free to write any questions or comments you have along the way in this question panel. We have planned the webinar for about 30 minutes of presentation time, followed by another 40 minutes to respond to any questions you submit during the webinar. So please share your experiences, comments, and questions so that we can have a rich discussion following the talk. Please note we won't be stopping during the presentation to answer questions or comments. During the Q&A session at the end, Jessica or I will read your questions and comments aloud to the group, and Oscar and I will answer and respond to them. We will address as many of your submitted questions as time allows. If we don't get to your questions by the end of the webinar, please don't hesitate to contact us directly. We'll provide our contact information at the end of the webinar. Also, please note this webinar is being recorded, and we will post the archive of the webinar on our website at www.communityscience.com within about a week. As we go through the slides, also note that the number for that slide is on the right top corner. You can use it if needed in your Q&A to refer to something specific that we shared. So let's begin. As many of you know, April is our National Minority Health Awareness Month. The theme for National Minority Health Month of 2015 is the Heckler Report, in honor of the 30th anniversary of the release of findings from this report. The Heckler Report, named after its author, Margaret Heckler, documented the existence of health disparities among racial and ethnic minorities in the U.S. and called such disparities an affront both to our ideals and to the ongoing genius of American medicine. The report is celebrated because it mobilized efforts to end health disparities among the racial and ethnic minority groups across the nation. While we've made some progress, 30 years later, achieving health equity continues to elude us. One of the key reasons health and healthcare disparities continue is that healthcare coverage gaps remain. Research consistently links lack of coverage with higher rates of morbidity and mortality due to lack of access to care. The passage of the ACA in March 2010 marked an important change in the history of healthcare reform in the United States, introducing a number of new provisions to expand health insurance coverage for previously uninsured or underinsured individuals. The ACA now serves as a powerful tool that we can leverage to address racial and ethnic gaps in coverage. Yet for this to occur, there must be widespread education about how to get health coverage. And that requires informing hard-to-reach, racially and ethnically diverse populations about eligibility, qualifications, benefits, and ways to enroll. Because enrollment was a little slow among racial and ethnic minority communities early in the first open enrollment season, a number of groups concerned about equitable implementation of the Affordable Care Act began conducting grassroots outreach to raise community awareness about the Act's provisions. These groups included the Regional Health Equity Councils of the National Partnership for Action to End Health Disparities, otherwise known as the NPA. The NPA is a national initiative to increase the effectiveness of health equity efforts led by the U.S. Department of Health and Human Services Office of Minority Health. When the NPA was launched, it formed 10 Regional Health Equity Councils, or RHECs, as we call them for short. The role of the RHECs was to facilitate collaborative action and collective responsibility to address the root causes of health disparities. The RHECs are comprised of a diverse group of people, from academics to health systems representatives to state legislators to community and faith-based leaders. While one of the NPA's foundational goals being to improve health and healthcare outcomes for minority, racial, ethnic, and underserved populations, the RHECs recognized that the implementation of the ACA was an imminent opportunity to initiate grassroots action to increase access to quality health care. So Community Science evaluated some of the RHECs outreach efforts during this first enrollment period. The RHECs were located here in the Great Lakes region and here in the Southeastern region. We are happy to share our lessons today from these efforts in today's webinar.
Thanks, Ken. Before we continue with our webinar, we'd like to take a moment to conduct a quick poll with you all just to set the stage. As you may know, the Obama administration announced in February at the close of the second ever ACA open enrollment period that nearly 11.5 million had signed up for health insurance through the federal partnership or state-based marketplaces nationally. The chart you are now seeing shows that although the total numbers are strong, there was a great deal of variation across states in enrollment. So in 6 states shown here, more than half of the potential market signed up, and by potential market, that's defined by Kaiser Family Foundation as legally residing individuals who are uninsured or purchase non-group coverage, have incomes above Medicaid CHIP eligibility levels, and who do not have access to employer-sponsored coverage. But in 4 states, less than 25% did. Florida led the way with 64% of the potential market and 1.6 million signed up. Iowa was at the bottom of the list with 20% and 45,000 people signed up. So the question that we would like you to think about is, which of the following do you think contributed most to the variation between the state sign-up percentages? Please take a moment to vote now as I read the question responses aloud. A, states with high sign-ups had more trained navigators. And by the way, just so we're all on the same page, a navigator in response A is an individual or organization that's trained and able to help consumers as they look for healthcare coverage options through the marketplace, including completing eligibility and enrollment forms. Their services they provide are supposed to be unbiased and provided free of charge. B, states with low signups were politically anti-ACA states. C, states with high signups had effective outreach. And D, states with low signups had poorly run state websites. I'll give you just another moment to finalize your answer. Then we'll briefly discuss the results of the poll. Okay, so we're wrapping up the poll now. Any stragglers, get your answers in, please. All right, so a lot of you have responded. So let's close the poll now. So the results are in, and it looks like the majority of you, 56%, selected C. 21% of you selected A, 19% of you selected B, and only 4% of you selected D. That's interesting that the majority of you picked C. So let's take a minute to discuss the responses. Response A suggests the reason is largely because states with higher sign-up percentages had more trained navigators than any other state. This may be a contributing factor, but for Florida, having more navigators per person was not the case. Florida is a fully federally facilitated marketplace, and because of this, the state received less funding for navigators and other in-person assistance for enrollment. In states with state partnership-based marketplaces, there were about twice as many assisters available per 10,000 uninsured compared to states with a federally facilitated marketplace like Florida. Response B suggests those states with low sign-up percentages were anti-ACA states with political barriers to enrollment. We also see that this may have contributed, but Florida stands out as an exception yet again. Florida's Republican leaders have fought the Affordable Care Act at every turn, banning navigators from county health departments, offering no health dollars to boost outreach, and leading the fight to repeal the law. Yet Florida has emerged as a success story for enrollment. Response D, states with low signups had poorly run state websites. This could also have been a contributor. For example, we know in Nevada, the governor embraced the ACA, but Nevada's state-run website did not perform very well, leading to a late switch over to healthcare.gov and lower sign-up percentages in Nevada. Yet we also know many of the states with low enrollment did not have state-run websites, and the residents were only able to enroll through healthcare.gov. So if you haven't guessed by now, we think that response C, states with high sign-up percentages had strategic, effective outreach, maybe the biggest contributor. Some of the lessons from high and low state sign-ups will take time to discern, but Florida's success in particular is due at least partly to infrastructure created in the swing state by Democratic-affiliated groups during the last 3 presidential elections. This infrastructure allowed outreach groups to leverage deeply entrenched relationships in communities with information on resident needs and strengths and access to data to pinpoint the uninsured and track them down. Being able to target the need and having the local, cultural, and community-specific knowledge to motivate action to enroll among the uninsured is absolutely critical to effective outreach.
So, as you can see from this exercise, examining state variation in ACA enrollment, just how important effective outreach can be for the bigger picture of expanding health insurance coverage among the uninsured and underinsured. Effective outreach is absolutely essential to ensure that ACA provisions are equitably benefiting everyone, including hard-to-reach, vulnerable racial and ethnic minority populations. And this was the central purpose of the outreach efforts by the RHECs that we are presenting on today. But a key question remains about how to assess whether our outreach efforts are effective. How do we know that? How do we know what's working? We know a little over half of you have engaged in ACA outreach work, and many of you may want tools to evaluate your impact. So let's turn to a discussion of the methods we use to assess the impact of the RHEC's outreach. Later, we will also share lessons learned about how to create an effective outreach strategy. As a reminder, again, the data we just presented on state variation reflects enrollment outcomes from the second enrollment period that was just closed. But the information we're about to present to you is from the first enrollment period for 2014. So in case you're looking for some sort of connection between what you just saw and what we're going to be sharing, just note that there really is none other than effective outreach is absolutely key and should be evaluated so that we can continue to learn about what works and what doesn't work. So how do we assess outreach effectiveness? The first step really is to develop a measurement framework. When we first learned that RHEC members were mobilizing and planning to conduct outreach and education events, we had conversations with them to determine their objectives and expectations regarding the events. We also discussed the information they would be presenting, the method of delivering the information, and the populations they were targeting. Based on this initial discussion, our evaluation team started to sketch out a measurement framework. This exercise required that we clearly define what it meant for the outreach and education event to be effective. We then developed our measurement domains based on the Kirkpatrick 4-level training evaluation model: reaction, learning, behavior, and results. This model emphasizes the importance of knowledge gain as a precursor to behavior change. So, measure domains related to perceived knowledge gain and intent to take action. Starting here at the top, you'll see we looked at event reach and engagement as indicators. Reach was operationalized as the number of outreach events that took place as the number of outreach events that took place impacting how many individuals, getting at participant demographics in terms of age, gender, race, and languages spoken. Engagement was operationalized as the extent to which and how outreach strategies were tailored to engage and motivate action in specific racial, ethnic, and cultural communities. Also, we wanted to track what language assistance services were provided, if any. To measure knowledge gain, following each outreach event, participants rated their perceived knowledge of key ACA enrollment topics. Having this information allowed us to better establish links between actual enrollment and outreach efforts. To measure intent to act, we asked participants about their intent to enroll, make an appointment with a navigator, gather more information, or do more thinking. Because I'm sure many of you have experienced in your own outreach work, it's not always possible to track enrollment of those we engage in our outreach. Therefore, establishing the link between the outreach exposure and the intent to take action allowed us to draw more credible links to actual enrollment. Once we had measurement domains, we developed a set of items that addressed the measures. The first iteration of the instrument was a couple of pages long because we wanted to know everything there was to know. The event organizers provided us with consistent feedback that the populations that they were trying to reach and the method in which the information was going to be delivered would no way allow participants to complete a 2-page assessment. So we then selected the most appropriate items and cut it down to 1 page. We also made a number of modifications to the form to make it more accessible to lower reading levels. We settled on a 3rd-grade reading level for all items. I cannot stress strongly enough how important it is to establish a good working relationship with the event organizers and those who assist them in coordinating the events. They know what is likely to work and not work with their target population. Having this early feedback was essential in making that data collection efforts effective. Another important step was getting all event organizers to agree on the content of the ACA information they were going to share. We reviewed their presentation slides and information flyers, and we also reviewed the ACA resources available through the Centers for Medicare and Medicaid to ensure consistency with their information. So what you see here on the screen is the assessment form we came up with, that one-page form that addressed all the measurement domains. For knowledge gain, here at the top, we assess changes from before to after the outreach encounter in 5 key content areas: health benefits under the ACA, types of policies available in the marketplace, how health insurance works, ways to buy insurance in the marketplace, tax credits and other incentives. The approach used to assess knowledge before and after the outreach event followed a retrospective pretest approach. This approach simply means that we ask the participants what their perceived knowledge is on a given topic after the outreach, and then we ask them to recall what their knowledge was on the topic before the outreach. This is done on the same form because we had to keep it all to one page, and research by Kim Neiman at the University of Texas suggests that if used correctly, the retrospective pretest can perform with similar validity to separately timed baseline measures and post-exposure follow-up. For behavior change, we looked at 4 specific stages of change. The first stage was to do more thinking about options. The second was to actually go out and gather more information. The next would be to make an appointment with a navigator or in-person assister. And the last would be to actually enroll in a health plan online or via the 800 number. So because we couldn't track what participants actually did, the next best thing was to get their intention to take these specific actions. And here you'll see below, we also asked certain questions about demographics: gender, language assistance, age, languages spoken at home, etc. Once we finalized the form, we coordinated with our partners to create translations of the form in Spanish, Hmong, Korean, and Mandarin Chinese. So what you see on the screen here is on the left in Korean and on the right Mandarin Chinese. Since funding was very limited, we shared translations among partners to leverage resources. However, sometimes different dialects and different ways of speaking meant translations needed to be tailored to the local context. This was difficult to balance with the need for consistent messaging in the items and the in-depth process of back translation that can sometimes be required in the translation process. So these are some of the challenges that required forethought and review and feedback from event organizers. Our next step was to provide partners with training and technical assistance in procedures for administering this assessment form. The training and TA we provided included consultation on event setup and flow. For example, how should the data collectors be stationed to maximize the response rate? Is there a way to block off exits so as to encourage people to exit through the door where the assessment form deposit box was? So we really had to think about the space as well. We also provided samples of completed evaluation forms with instructions for participants during our orientation and training of data collectors. And although for the most part data were collected via paper and pencil, we also created mechanisms like QR codes and bit.ly links to facilitate online data collection using Qualtrics software. Our objective really at this stage was to make sure that our partners collected quality data in a consistent and efficient way. Then we also wanted to gather another perspective beyond the participant's perspective. In particular, we wanted to hear from navigators, event planners, ACA information presenters, community quote-unquote gatekeepers, and trusted leaders, and others engaged directly with event participants. So to get this perspective, we created the semi-structured interview protocol that asked stakeholders about their target population strengths and gaps in resources, how they developed and tailored their strategy to engage their target population effectively, what the indicators of success were that they were looking for, what factors they felt contributed to the success they had, and what recommendations they will make for the upcoming enrollment period. So these discussions allowed us to better understand the strategy employed to arrange the event and to identify potential indicators of success and what factors contributed to the success. So in total, we conducted 8 interviews with event organizers 3 with community leaders, 2 with presenters, and 1 with navigators that participated in the events. We'll discuss some of these findings from these interviews in the later part of our webinar.
Thanks, Ken. So now I'll present the findings from our evaluation of outreach during the first enrollment period so that you can see what kinds of information such an assessment is able to produce. Participant-level data were submitted on 29 outreach activities co-sponsored by the Southeast Health Equity Council, RHEC-4. This is the HHS designated region including Tennessee and Georgia, and the Great Lakes Regional Health Equity Council, RHEC-5. This HHS region includes Michigan and Ohio. The majority of the events took place in the Great Lakes Regional Health Equity Council, with 15 in Michigan and 11 in Ohio. However, Tennessee, with only 1 event, contributed a large proportion of the outreach participants we studied because the event type was a large conference, a National Christian Women's Retreat. In addition, we assessed 2 outreach events that took place in Georgia. All total, activities reached 2,255 participants, and data were received from 819 respondents. The response rate wasn't great. It was 37% on the low side, and suggests that additional incentives may be needed to encourage participation in data collection with these types of events. We were also able to determine that the majority of events were targeted to African American communities. However, a significant number also reached diverse Asian populations, East Asian, South Asian, and Southeast Asian. There was also a focus on specific underserved populations like the prisoner reentry population. Here we can see that the majority of participants were African American, followed by Asian Americans. The majority of participants, 65%, were female and were between the ages of 35 to 64. So that was the reach achieved by the events. Moving on to the knowledge gain domain, event participants were asked to rate their level of knowledge before and after the event. The rating scale was a 3-point scale asking participants to rate their knowledge as poor, fair, or excellent. In each topical area addressed by the outreach, from the benefits of health insurance to how it works to ways to buy, we identified statistically significant gains in perceived knowledge among respondents before and after the event. Again, using the retrospective pretest approach Ken described earlier. These findings suggest that there was an impact on knowledge of key content areas, with the greatest knowledge gain in ways to buy insurance and tax credits, and the lowest knowledge gain in how health insurance works. So you can see for the difference in ways to buy, this was an increase of nearly 1 point on a 3-point scale. Next, as discussed earlier, a critical component of the Kirkpatrick model is the assessment of the intent to act on the information learned. The prompt was, please indicate what you might do following today's event. And the response options were on a 3-point scale, including not at all, maybe, and definitely. When participants were asked what they intended to do next following the outreach event, the actions with higher ratings of likelihood among respondents were in the earlier stages of change, including doing more thinking and gathering more information. Reported likelihood of making an appointment with a navigator was lower, and reported likelihood to actually take action to enroll by using the website or 800 number was the lowest. These findings were lower than we were anticipating, especially since these events took place right before the first open enrollment deadline. Folks were just not ready to enroll. This piqued our interest, and we were able to learn why by reviewing the qualitative data we collected from event organizers. The interview data showed that potential enrollees were not ready to enroll by the deadline due to significant challenges associated with the enrollment process. For instance, the questions enrollees were asked on the website were perceived as complex. Many enrollees were stymied by seemingly simple questions like, what is your annual income? For those that are self-employed, day laborers, or otherwise have unpredictable income, that question is not easily answered. Also, some of the questions asked were perceived as invasive, or the process was otherwise anxiety-inducing for documented immigrants eligible for marketplace insurance options, but who had undocumented family members that they were wanting to protect. We also learned that establishing trust and security of information provided, particularly when encouraging online enrollment, in addition to highlighting the benefits of healthcare coverage, all those are key to motivating action to enroll underserved populations. Also, a substantial proportion of older adults reported a lack of access to and comfort with technology. Given reliance on online enrollment mechanisms, including healthcare.gov, but also sometimes poorly performing state-run websites, it became clear that additional training may need to be built into outreach targeting this population that focuses on some computer and internet basics. These trust issues, the complexity of enrollment questions, and lower tech literacy among older adults highlighted the importance of ensuring that consumers can access in-person assistance with enrollment. In fact, we found that events with on-site navigators provide a solution to a number of enrollment barriers. However, we also found that during the first open enrollment, the navigators were particularly scarce. And when available, they were not always sufficiently trained to responsibly provide assistance in hard-to-reach, underserved populations. Ensuring the availability of bilingual in-person assisters, as well as ensuring cultural competence training, is required as a component of navigator grants and may be important to ensuring more equitable implementation of ACA provisions. Finally, one of the most prominent findings we had during the first open enrollment period was the need for improved health insurance literacy among potential and new enrollees. Having a basic understanding of insurance terms is necessary to make informed decisions about policies during the sign-up process, but it's also critically important to ensuring that newly acquired health insurance coverage is well utilized. We heard directly from event organizers that folks didn't understand basic health insurance terminology, like what is a copay, what's a primary care physician, what's a deductible. Very basic terminology was absent. As one of our interviewees noted last year, "Hey Obama, thanks for the license, but I don't know how to drive yet." To address this health insurance literacy gap and promote utilization, the Centers for Medicare and Medicaid Services developed the From Coverage to Care campaign. The campaign materials developed were designed to be user-friendly for consumers and have been translated into multiple languages. So this year, the Office of Minority Health is supporting evaluation and research exploring outreach events that are designed to promote both enrollment and healthcare utilization. So we might be holding another ACA webinar covering our findings specific to the health insurance utilization outreach sometime in the near future. So stay tuned.
Thanks, Oscar. And hopefully we'll see a slight difference, too, in the second enrollment period results because the lessons from the first enrollment period would have been applied. So what are the lessons learned about designing effective outreach? The most significant recommendation we can give others based on our findings and our experience in designing and evaluating ACA outreach is to design outreach events by first understanding how a community is organized. Well, what does this mean? All communities, no matter what community, they're all organized in some form or shape. And by this, we mean that there are go-to people, there are leaders that you may not know about if you're an outsider, there are ways to get information, authentic information. And so if you're an outsider and you really don't know how to access the community's social organization, it would be best to partner with someone who actually knows that community well, quote unquote an insider. Or, make sure that you really spend a lot of time understanding that community before doing anything. This includes actually walking the communities with no assumptions, about how you are being perceived by others or how others perceive you, but being very open to that experience and knowing that everybody, including yourself, may have some biases that you have to check as you work in some of these communities that are hard to reach. and often have a distrust of outsiders. For example, one of our interviewees shared with us that she has her doctorate, but the women she was reaching out to couldn't care less about that qualification. She said they wanted to know who was her mother and where she went to church. Remember that the building blocks of community trust differ significantly by the cultural values of that community. And what may give you authority and credibility in one crowd won't accomplish that with another audience. So as an outreach organizer, what you need to know is how to work with the people in that community. And with this particular person, he or she had to go get to know the pastors of the churches where they wanted to do outreach, and then had the pastors vouch for them in front of the congregation before actually delivering that information on the ACA. And that made a huge difference about how the information was received. Also, you can't advertise in mainstream outlets and expect to gain traction with hard-to-reach communities. Not only are the outlets usually in a different language than the population's native tongue in many instances, but these outlets may not have the same credibility, and local cultural specific outlets like the local Spanish station or newspaper would actually be more effective. We also learned that you cannot expect hard-to-reach communities to come to you by holding an event somewhere central and then inviting them to come. Instead, go to where they're already going to be. Go to those naturally occurring places. So some strategies included tabling at the local H Mart or other Asian grocery market when trying to reach that population. For others, it could be going to a temple, the library, the community health clinic, and so on. It's really important to identify where those hubs are for the community you want to reach and to strategically locate your outreach efforts during high traffic times. Finally, it is critical to understand the specific community's concerns in advance and how they can be resolved in order to develop and communicate effective messages to encourage enrollment. If an individual is afraid to divulge information due to their living in a mixed immigration status home, i.e. they're members of the homes that are both documented and undocumented immigrants, it's important to be sensitive that this is an issue that you're trying to deal with, and to learn whether there are real concerns to overcome or whether you need to clarify your messaging, and whether you need to bring certain information that will answer those questions right away rather than leaving the families kind of hanging out there. This means training in-person assistants in general, cross-culturally competent practices, but also doing your own research in advance in the community and getting the pulse of that community on these kinds of issues.
Thank you, Kim. Okay, so we've just covered what we were able to learn from assessing outreach and education events using the strategies we described. I think you'll agree that this basic approach can yield a lot of useful information. Now, to close out the webinar, I'd like to recap some of the key strategies to assessing outreach events that we've discussed. First, you have to spend some time developing a measurement framework that defines what effectiveness means for you and your partners. For us, it meant reach, engagement, knowledge gain, and intent to act, but you may have other indicators you may want to track. From there, you can create your instruments based off of the measurement framework. And as we discussed, we spent a lot of time discussing the instrument development. It's really key. The questions need to be tailored to the material that is being delivered. Collect information on key measures of success and be adapted to the reading level and language of the target population. The best test of whether the instrument will work are the individuals that organize the event and interact with community members. That's your best pilot test. Another key to having a full understanding of the outreach is to collect data from multiple perspectives, not only from those who participated in the event, but also those that organized it and interacted with its participants. This mixed method approach will add richness to your findings. When it comes to administering the tools, you'll need to work closely with your event coordinators. Depending on their level of experience with collecting data, some partners may need substantial technical assistance, and you'll need to carve out time and staff resources to accomplish this. Also, you need to leverage every dollar possible from your outreach work. So when translating assessment forms, build on the resources and expertise within your network of partners to create translations as needed, and be a conduit for sharing translations of evaluation and outreach materials. Finally, consider the options that are going to work best for a given event to administer a survey. In some instances, you may want to collect data using mobile devices, and if so, it will help to develop bit.ly links, QR codes, and online data collection tools. We use Qualtrics software for this, but there may be other options.
Well, Kian and Oscar, thank you so much. This has been a wonderful presentation and discussion of the issues. We received some comments. Would encourage folks, if they have questions, to go ahead and write them in, and we can dig into them and get started in this Q&A session of the webinar. I'm just going to be addressing the questions in the order that they were received. And so one of the first questions you all might be expecting actually is that there is an interest in this evaluation tool. And so perhaps you want to talk about the evaluation tool and our ability to share it.
Yes, absolutely. We will make it available. Our contact information will be at the end of this presentation, and you can certainly take it down. We will share the form we use from the first enrollment. The form that we're using for the second enrollment right now is still kind of being implemented, and it was improved based on that first round. So we will share that once we close out the data collection for the second round, but we're more than happy to share the ones for the first round.
Great. So another question that we had was just about why the 2 RHECs were selected, and whether all the RHECs were given resources to do ACA outreach. And there's a particular interest in RHEC 1 in the region in RHEC 1 where Maine is, to know if this work can be extended there.
Yes, so all of the RHECs were given the opportunity to work on outreach, and we as the evaluators did reach out to all the RHECs. And so the 2 that came forward and were really already in the middle of planning their events and engaged in early talks on partnering for these events were the ones for which it was easiest. So the response is all the RHECs had the opportunity.
And another question we had was about the demographic breakdown of the target population. So knowing that the results sort of presented the demographics by race, ethnicity, sort of following the U.S. Census designations, and just an interest in whether or not there's any potential for further breakdown into country of origin.
It would be great if we could. I think the challenge was keeping it all into one page. As you can imagine, once you try and break it down by country of origin, you get into a lot of countries, and that page gets long, and we really had very strong feedback from everyone that it had to be short. We considered an open-ended option that allowed people to write in, but that meant also data entry of hundreds and hundreds of forms in order to analyze that information. So we stuck to what we knew would allow us to compare to other data sources, which was the census categories.
So relatedly, there was a question about whether or not we were collecting information about the income range of the attendees, and to see if there was any differences by income. Which
income made it into the first version of the form, and as we were given the feedback that we needed to scale back, we ended up dropping it. We just wanted the bare basics so that we could run our analyses. And again, it all goes back to being very clear about what does success mean in terms of outreach. And so a lot of these events were organized by individuals that work in the community, and they had a very good idea of who their target population was. And so income, I would say that the great majority, if not all, of event participants had very low incomes.
Yeah, this was a difficult choice to make. These were the difficult choices when we had to cut the form down. And, it essentially came down to what our partners from those RHECs in particular most wanted in terms of information. And so those demographic categories that you saw in the form really took priority for them.
Yeah, so this question was from Kenneth, and he was just really interested in whether or not there were differences in intent to act by whether or not their income range fell into sort of a marketplace exchange range or a Medicaid expansion range. And so I think it's an interesting question, but it does point to some of those challenges in collecting the data that's needed to really assess these questions. So I think there was another question about incentives that were used during the outreach activities. So the question was whether or not you all could elaborate a little on the incentives.
Yeah, so that's a really good question. And as we noted, the response rate was on the low side. And what we heard from the event organizers is that they really struggled just to put these events together. There was a lot of partnerships, a lot of alliances that were created in order to get these done. And when it came down to incentives, there just was no funding available for them. And that is actually something that for the second open enrollment for our research, organizations were able to offer small incentives. And from what we've learned to date, they're using gift cards, the raffle. They enter them into raffles, those sorts of things. But to answer the response here is that there was very little. There was no incentive for these events for filling out the forms. For filling out the forms.
Right, so a lot of the partners sort of came up with creative alternatives to finding those resources by partnering locally to get gift baskets or other options. So it sounds like there's another question here that's sort of a bigger picture question that you all might want to address. How do you, Kelly asks, how do you define the difference between access and coverage? So she says, we all know that sadly having coverage through health insurance does not equate with access. So what do you all think about that?
Right, I think that gets into the research that we're currently conducting, which is utilization. And gaining that access to preventive care that ACA provisions now are delivering, that is a big question. That's something that we're exploring. But what we've been hearing is that with this greater access is a lot of bottlenecking within the health insurance providers, where now they're serving millions more and with limited resources. So yes, that's a question that we're definitely very interested in exploring.
And I would imagine there are also other contributing factors to access. Yes, definitely you can get coverage, but whether or not you have access, like whether or not you know how to use that, your health insurance, whether or not your providers are even culturally competent providers, whether or not they're located in places that you can easily go to get health care. There are all those issues that are related to access that we have yet to even dig into to really understand the true benefit and impact of giving people insurance.
Right, that's so key. So getting into some of that, someone had a question about specific tips for outreach for Spanish-speaking and Latino communities in particular. This is Ronnie, who says, we have small but growing populations, but have not had the response they hope to get. And they do have Spanish-speaking navigators.
Yes.
So do you all have thoughts about that?
Yes, the one thought that comes to mind is that the outreach that we're evaluating this year really focused in on the Latino populations across the country because of that of the low percentages of new enrollees, and what our partners are focusing on is it's basically what we said, meeting them where they are, going to them. And so a lot of the outreach focused on going to where Hispanic foods are sold in bodegas, and going to community health centers, and being very upfront with them about the fact that the application process is completely confidential, and so that's what we've learned, that the Hispanic population does need a little bit of a different treatment in that regard.
I also think that there's more effort for the second enrollment, and I believe CMS may have put more information together to assist with answering questions about mixed status families. So I think in the first enrollment period, navigators, assistants may not have been prepared to answer some of those questions. And the policies can be confusing. What the policies are related to health insurance with what immigration policies are sometimes can conflict and be confusing about what type of benefits you're eligible or not eligible for depending on your documentation status. So I think that's another big area where hopefully it's better this second enrollment, but something that any kind of outreach activity for Latino communities really needs explicit attention.
Great. So this seems to be generating a few questions we can discuss. This is an interesting topic, I think. And so Kenneth writes in about what the concerns about immigration status were, whether they were similar for mixed status families in Asian American backgrounds as they were for Latinos. So questioning whether or not for Latinos there may or not have been more concern and anxiety around that issue than for Asian Americans.
Yeah, I mean, we don't have any facts, but I think the general experience, or at least the general perception, is that there tends to be a higher undocumented population and thus mixed family status among the Latino population versus the Asian population. But, we know that there are undocumented Asian immigrants as well that come in, and so they have mixed status families too. But I think the issue just tends to be associated more with Latino communities.
Right. So, and I think we saw a low turnout with Latinos, and so I think that could have been one of the reasons that contributed to it, and we did hear some of that anecdotally. Mm-hmm. So another question about a specific population that we have here from David asked about projects working with inmates in jails and the prisoner reentry population, and if we had come across any projects working with that population.
No, not that we can think of right now. I assume that there are some out there, but we can't think of any right now. And whomever asked the question, if they're interested in getting more, we'd be happy to look into this some more and send you the response. I'll send you the information we find. You can write either of us at the end of this.
Right. So we did have another question about the methods. It was about the tracking the actual outreach events and how we worked with the facilitators to collect logs of what happened at these outreach events. So, Oscar, perhaps you want to talk a bit about how we worked with those facilitators to get that information?
Right. So what we did was we interviewed the event organizers before and right after the event, and as we showed, the line of questioning focused on, what was the overall experience, and part of those questions were on numbers, and some of them had sign-in sheets that they submitted to us. Others did head counts at their events, and we did talk that through with them. So those final numbers came to us through our interview, our post-event interviews.
Great. So then it looks like we do have some questions more on the results side and the analysis as well. And so Ashley writes in, did you look at how dosage affected knowledge or intent to act? For example, if the length of the outreach event or the type of outreach offered made participants more likely to be in the later stages of change or more likely to take action?
So no, we didn't look at dosage. All we did was document the type of outreach, and we are able to describe that. But we did not conduct a more thorough analysis that focused on that last year. Now this year we are more focused on what the outreach strategy is like, and we do collect more detailed information from our event organizers, and we will be conducting those types of analyses.
Great, I think that's going to yield some really interesting information. Looks like we have another question about getting back to these cultural adaptations. I'm wondering, sort of aside from those cultural adaptations that were made for the target audience, they're wondering how similar the outreach events were and if they covered the same topics and content. This is from Nanika. I'm saying that right, I hope.
Yeah, so when we first started our discussions with
So sorry, everyone. It looks like my audio disconnected. Hopefully you all can hear me. I don't think we had too many questions left. But there was a few more questions. There was someone in San Diego County talking about their work doing extensive outreach and enrollment on reentry. So for the person who was interested in that, I believe it was David Young. Perhaps you want to connect with Clovis here. So the last question here I'm seeing now from Nanika is, will the in-depth interview guide be used with event coordinators?
Yes, we can share the interview guide, absolutely. If you want to write us again at the end, we can definitely share that.
And it looks like Gina has written in with a question. Could you elaborate on your current study with regard to utilization versus access and how we are measuring utilization?
Yeah, so what we're focusing on with utilization is do event participants that were newly insured last year, have they reached out to their primary care physician, made an appointment, started to use preventive health care services with their policy? And so the questions focus on, do you have a primary care physician that you regularly see? Have you attended preventive services with your primary care physician? So it's basic questions like that that we're starting to address.
Great. Well, thank you, Oscar. Someone else has written in with a question around CEUs, and actually if this is something that we can provide any kind of certificate of training to this workshop today.
No, I don't think so, but I will follow up, but I don't think we can provide such a certificate.
Well, it looks like we are just about done with the questions here. We hope we've answered most of them.
Thank you. So just to wrap up, we'd like to thank everyone for participating in the webinar. Just want to make sure that we acknowledge everyone who helped out, Jessica Botiani and Margaret Peck from Community Science, and our partners established key partnerships to make this event a success and provided us the information. Ophelia Pryor from Michigan Minority Health Coalition, Manju Sankarappa from the Ohio Asian American Health Coalition, Sherry Houston from the Critical Learning Systems, Nicey Johnson from VSNS Inc., and Zykia Slowly from the Center for Pan-Asian Community Services. We also want to thank OMH for its support, which allowed us to collect this data and share the lessons learned. Finally, unfortunately, I think our last slide is not pulling up, but if you want to reach us, I'm Kien, K-I-E-N, at communityscience.com. And Oscar is at Espinoza, E-S-P-I-N-O-S-A, communityscience.com. Please feel free to write us with any information that you want to share or anything that you want from us. Thank you and have a wonderful day.